I'd like to introduce you to Dr. Rutten. Dr. Rutten is an interdisciplinary scientist with expertise in social and behavioral science and has done a lot of implementation science work. Her program of research examines factors related to cancer control and prevention, and she also does a lot of evaluation of evidence-based cancer prevention and control strategies to control to improve population health. She's currently a professor of health services research at the Mayo Clinic College of Medicine and the chair of the Division of Epidemiology at the Department of Quantitative Health Sciences at Mayo Clinic. So with no further talking from me, I'd like to thank Lila for coming to town to talk to us. And I want to give you the special present that all seminar speakers get.
Oh,
A seminar glass.
wonderful. Thank you. Perfect. I'll keep it with my, I have a mug from presenting at your population health science.
Oh, you're collecting them all.
Good.
Yes.
Thank you. So thank you so much for the warm welcome and for the opportunity to be here today. I learned recently that the School of Public Health and the Medical School at the University of Minnesota was actually started with an endowment from the Mayo brothers. So there's been a long-standing relationship between our institutions, and this is a relationship that, as division chair at Mayo, I'm interested to really foster. And so, you know, we're looking for opportunities to work together. So I'm excited to be here today to share a little bit with you about a study that we recently completed, looking at an intervention to increase HPV vaccination. But I'm going to couch it within the broader context of the research that I've done in this space that really shows the ways that learning health system science, implementation science, and pragmatic research can help bridge the gap between evidence and practice. So I'm going to take you on a little trip, if you'll allow, and our itinerary starts by talking about this gap between research and practice, and then discussing the role that the learning health system science, implementation science, and pragmatic research can play in helping create a bridge between evidence and practice. And then I'll share the example that I alluded to on HPV vaccination. So you're likely familiar with the pivotal trial or pivotal report that was published several years ago, highlighting some of the deficiencies in the healthcare system in the US and delineating a roadmap essentially for crossing the quality chasm between what we know and what we do. And the destination is our collective destination, healthcare that is high quality, safe, patient-centered, and evidence-based. Does anybody care to hazard a guess as to when this was published? It's 2001. I was shocked when I saw that. It's over 22 years ago. And so that raises the question, are we there yet? And have we crossed the quality chasm? And if some of you are adamantly shaking your head, no, we have not. I think progress has been made. I think that there has been, over the last couple of decades, greater focus on quality and safety in healthcare. And certainly there's been widespread adoption of health information technology to support quality and safety in healthcare. There's been increased focus on engaging patients in healthcare process and delivering care that's patient-centered. And there's also been movement toward value-based care, movement away from fee-for-service models. And then finally, I think there's been a real growth of research and innovation in healthcare delivery. But nonetheless, I think we all agree we haven't crossed that gap, and we haven't closed that gap. So while progress has been made, challenges remain, and as healthcare research and practice evolve, new challenges have emerged and continue to emerge. And while evidence generation has become prolific, only a small fraction of the evidence that is generated is actionable. in healthcare practice, in clinical practice, in public health practice. So even when we have guidelines and some sort of consensus around the evidence, the adoption and the equity of implementation of that into practice is still wanting. You've likely seen this 17-year odyssey between original research evidence and population health benefit. So we know that on average, it takes about 17 years for research evidence to make its way into clinical practice or public health practice. And when it does, only about 14% of it actually does. So clearly, there's a critical need to increase the speed and efficiency with which research moves into practice. So here's our path forward. Learning health system science, implementation science, and pragmatic research has really grown up under this critical need to respond to this critical need. And the learning health system science we can think of as our roadmap, a process wherein you generate and apply evidence embedded within the healthcare system or public health system. And implementation science is really our toolkit. It provides us with local guides for our journey. Those are our stakeholders, and route planning, theoretical frameworks that help you couch your research questions and your metrics, and then fuel, implementation strategies. There are a number, I think at last count it was over 70 evidence-based implementation strategies that can be put to work to move evidence-based interventions into clinical practice. And then finally, you have your travel log. And this is really where you pay attention to and you're mindful of recording adaptations to your interventions throughout the journey. And then lastly, we hit the open road, and this is the pragmatic research. This is doing embedded real world evidence collection in the clinical practice. So you're familiar with learning health system science. University of Minnesota is really leading this space in the state, and you have a center dedicated to learning health system science. And this is really a research process that's embedded in the clinical practice to continually collect data and improve care in an evidence-based way. And so this process, as I mentioned, is continual, starting with an internal and external scan, identifying what the problems are and working together with key stakeholders to identify feasible and innovative solutions. And then you move to design. This is where you design care, design interventions, and your approach for evaluation and approach for implementation. And then you continue in the cycle to implementation, where you actually implement your plan and move toward evaluation, where you collect data to understand, was it successful? And then looking at the data, you make adjustments to inform improvements, and then disseminate those results, and the process continues from there. This figure really shows a high-level overview of implementation science. I could stand up here for, I could give an entire course on implementation science, but I'm going to try to give you sort of a high-level overview of what it is and what some of the key components of it are that's relevant in the context of a learning health system. So implementation science, this is a conceptual model that captures key components, and implementation science is really the study of the methods to promote use of research evidence and policy and practice. So the idea is that you study these processes in order to improve them. And that should help speed the efficiency with which we can move evidence into practice. And so I'm just going to lay out some terminology here to keep straight sort of what I'm referring to. We have intervention strategies, which are evidence-based practices or evidence-based interventions, EBIs, that work. Those have already been evaluated through clinical trial, and we know this works. But then you have implementation strategies. And these are really the approaches and the methods and the efforts that you take to move the evidence-based interventions into practice and to overcome some of the barriers to moving it into clinical practice and to sustain those interventions over time once they've been adopted in practice. And then in implementation science, the breadth of outcomes of interest go well beyond effectiveness. Include implementation outcomes, service outcomes, and client or patient-facing outcomes. And implementation outcomes speak to issues such as acceptability. Was the intervention acceptable to the target audience? Adoption. Did they use it? Did they adopt it? Was it appropriate for the setting? What were the costs associated with it? Highly related, was it feasible within that context, within the resources and the needs of that context? And fidelity, which is how closely did people adhere to the components of delivering the intervention? And then penetration is similar to adoption, but somewhat at a higher level, like what's the reach of the intervention? And sustainability speaks to, are there resources in place to sustain the intervention over time? And there are metrics for all of these that have grown up in the somewhat new area of implementation science that you can use and apply to your own research to better understand. If you evaluate an intervention, you want to understand, was it effective or ineffective because of the intervention itself, or was it poorly implemented? So these are the measures that help you tease that out. And then with regard to service outcomes, you're interested in efficiency, safety, equity, and patient-centeredness. Am I doing that? Okay.
Might be putting your hair a little bit.
Good now. There we go. All right. You're interested, this is really the quadruple aim that I alluded to earlier with crossing the quality chasm. Whether you're meeting some of those aims, our collective destination. And then finally, in terms of patient or client outcomes, satisfaction, function, symptomatology. So in addition to sort of disease endpoints, which are often a focus of our research, looking at sort of the broader spectrum of patient experience. And there is a set of methodological approaches that really support implementation research, and this includes pragmatic trials, and I'll give you an example of that. Effectiveness implementation hybrid trials, which really do both. They do the work of evaluating implementation, but also evaluate the effectiveness of your evidence-based intervention or your intervention. And then quality improvement studies, and then using mixed methods. So really triangulating around a research problem using both quantitative and qualitative approaches to addressing research questions. And this brings us to the open road where we can talk a little bit about pragmatic trials. But before I launch into that, I just want to talk a little bit about how pragmatic trials differ from explanatory trials. The trials that I think most of us are accustomed to are explanatory, where you're really looking to address a clinical or physiological hypotheses. And pragmatic trials are really more to inform policy or practice, or to inform decision-making within a certain setting in a real-world clinical practice or real-world public health setting. And trials aren't necessarily one or the other. I mentioned already sort of the hybrid approach, but really most investigations lie on a continuum between explanatory and pragmatic. And this continuum has really been captured across 9 different domains included in the pragmatic explanatory continuum indicator summary tool, or the PRAC tool. And this really lays out 9 different domains that you can consider in a research approach or research design to discern how pragmatic or explanatory your trial is. And the whole idea is to design a trial fit for purpose. right? You wanna make purposeful decisions across these 9 domains to match the intent of your research study or of your trial. And I'll walk you through a few of these just to give you a sense of the continuum here. So if you have an explanatory trial, and let's start at the top here with, you can see my cursor, probably not, with eligibility. So who's selected to participate in the trial? In an explanatory trial, you're going to have very tightly controlled eligibility criteria that you apply when you collect your sample for the study. But in a highly pragmatic trial, it's all comers. So if you're conducting a study in a clinical practice, everybody who shows up at that practice for whatever care you have under investigation will be eligible. The example that I'll share more details on for HPV vaccination, we did a pragmatic trial, and everybody who was eligible and due and went to that clinical practice was included in the trial. And we didn't include strict eligibility criteria. And so that gives you a sense. And similarly with recruitment, are you going out of your way to recruit people with very specific eligibility criteria to participate in your trial, a la an explanatory trial, or are patients recruited by virtue of receiving care at a particular setting? So now I'm going to move on to my example, and this is where we have a gap. We have a vaccine that prevents cancer, and adoption of this vaccine has been low and slow, and more recently has really leveled out. And so the work that I'm going to share with you is an attempt to try to close this gap between what we know and what we do. And this is my travel party. This is a fantastic interdisciplinary team of folks that I work with at Mayo Clinic, who bring expertise from various areas, including pediatrics, family medicine, implementation science, biostats, epidemiology, evaluation research. It's a great crew, and it's definitely the team that you need to tackle one of these projects. The pragmatic trial that I'm going to talk about was funded by NCI, and a couple of my colleagues have some disclosures where they received funding from industry. So phase 1, this is step 1 on our journey, and this is our internal and external scan. And I'm going to walk you through how we built this program of research that led to the eventual pragmatic trial. So we know nationally that there are over 33,000 HPV attributable cancers in the US every year. And as I mentioned, we have a very effective and safe evidence-based intervention, the HPV vaccine that's recommended for children 11 to 12, with permission to initiate the vaccine at 9 and catch up through age 26. But despite having an effective and safe intervention, as I mentioned, adoption has been low and slow. And there are various reasons for this, but this gap still remains, where you can see HPV being up to date on the HPV vaccine, which is shown in this sort of green-yellow line at the bottom, is significantly lower than other adolescent vaccines recommended to the same age group. And it's also significantly below the Healthy People 2020 and 2030 goal of 80% vaccinated. And this goes out to about 2022. It shows coverage, and this is data from NIST from the National Immunization Survey, Teen Survey, and goes out to 2022. And what we've seen since then is really, as I mentioned, that leveling out, where for HPV, we've seen it really stagnated about 60% of the population who's eligible being up to date. And then we've actually seen some detrimental effects on other adolescent vaccines since the pandemic. So we also know nationally that there are disparities in uptake. So across the US, you can see there's a lot of disparity by state. There are only 5 or so states that require this immunization for school attendance. And obviously uptake is much higher in those states than other states, but there's variability with certain regions of the country having lower uptake. And there's also disparities nationally that have been observed by urban-rural status, with rural populations having lower adoption, those who are uninsured, and among non-Hispanic whites. So we started to conduct research several years ago to try to characterize the problem more locally. You may know that most cancer centers are required to delineate a catchment area where they take care of the folks in their own backyard. And for Mayo Clinic, that catchment area is a 45 county region in southeastern Minnesota, western Wisconsin, northern Iowa. And so we started to dig into what does HPV vaccine uptake look like in this region. And it also maps to the footprint of our health system. So Mayo, you may be familiar that Mayo has sort of this large tertiary quaternary care center, but we also have a very large health system that spans across a big chunk of southeastern Minnesota and western Wisconsin, northern Iowa that's fairly rural. And so we too observed underutilization overall and disparities. And the disparities that we observed were also by urban-rural status, with higher uptake in the more urban areas and lower uptake in rural areas, and also by area level indicators of deprivation and individual or household level indicators of socioeconomic status. And so we were able to conduct research in this space to demonstrate a local need to inform and target an intervention. We also collected information from our stakeholders. So we did survey research with providers and with parents and patients to understand what are some of the factors driving either recommendation of the HPV vaccine among healthcare providers or uptake among really parents who make decisions in this age group. And so among providers, what we found is that, and this is very consistent with the literature, that consistency and strength of recommendation is a real driver of uptake. And being board certified in pediatrics versus family med, those docs are more likely to have higher rates of uptake in their practices, and having greater knowledge and having lower perceived parental barriers. And that's an important factor, because this is a vaccine that very early on, when it was rolled out, there was a uniquely early push by the pharmaceutical industry to get this to be school mandated, and it created a major backlash. And we have not recovered from that. And so a lot of sort of fear grew up around this, and there's evidence in the literature that points to clinicians treating this vaccine as different. And so you might go in to, bring your child in to get this vaccine, and they might say, oh, well, they're due today for their meningococcal and Tdap, but they could also get the HPV vaccine. Are you interested in getting that? And so it sets it apart, and parents wonder, well, why is that different? And their major source for information and decision-making about vaccination is clinician recommendation. And so for clinicians who think, oh, this is going to be battle, I don't want to have an argument with this parent, they may just avoid altogether recommending it. And patient factors, as we've seen in the national data, when there's lower population awareness and knowledge of the HPV vaccine, which is sort of step one of moving toward actually vaccinating among rural residents, those with lower education and socioeconomic status. So just before we started putting together our application for funding to do the pragmatic trial, we observed prevalence rates of initiation and completion in both our 11 and 12-year-olds and 13 to 17-year-olds below healthy people public health goals. And in our 11 and 12-year-olds, about half had initiated and 21% had completed. And then in our 13 to 17-year-olds, 65% had initiated and 40% had completed. So we definitely knew we had room for improvement. And so we started to look at the landscape for implementation strategies. And the Task Force on Community Preventive Services offers several evidence-based implementation strategies for increasing adoption of vaccination. And these include point-of-care prompts, and these are the prompts that the clinician sees that tells them the patient that they're having an encounter with is due. And vaccine protocols in Minnesota, those are called nursing protocols. And this allows nurse-only visits that are more convenient for parents. So nurses can vaccinate without a specific physician order. And then reduced out-of-pocket costs, and the Affordable Care Act went a long way to assist with this. And there are also programs that assist with this. And then patient reminder recalls. This is when there's some sort of communication that goes out to the patient or the parent of the patient to alert them to the fact your child is eligible and due for a vaccine. And then provider audit and feedback. And this is an evaluation either at the provider or practice level that summarizes performance along any number of metrics, in this case, HPV vaccination, to indicate how well is the practice or the provider doing on this metric. And when we looked at what was already in place at Mayo Clinic, our usual care strategy at that time included the point of care prompts, included the vaccine protocols, included reduced out-of-pocket expense. For example, participation in Vaccines for Children, which is a program for individuals so they can get the vaccine without out-of-pocket costs. We also participate in state registries, so we have the immunization reconciliation, and we, as a practice, had begun to initiate at 9 years of age. So the national recommendations, as I alluded to earlier, say 11 to 12 years old. But what we find in clinical practice is that by the time kids are 11 and 12 years old, they're not coming into the doctor as much. And so the opportunities to vaccinate become fewer and further between. And additionally, the younger the individual is, the better the immune response. That's why if you get the vaccine when you're 11 and 12, you need 2 doses. But if you get it when you're older, you need 3 doses to get the adequate immune response. And so we also offer injection site pain treatment with baclofen and lidocaine cream. My kids had this vaccine, and it's super painful. And so you get them there for the first one, and at the time it was recommended for 3, and then getting them back there for the subsequent ones is a whole different battle. So the interventions we had left at play was the reminder recall and the audit and feedback. And so that's what we focused our intervention on. And that brings us to the next stage of design. So we created sort of mock-ups of potential audit and feedback and reminder recall interventions. And we brought those to our stakeholders. So we had parent interviews and provider and staff focus groups to get feedback on each of these interventions. And this really allows you to blend what you know from the published evidence base about what works with the local context and local needs. So our reminder recall our funder really wanted us to do something, cutting edge, send it out as a text or put it through the patient portal. Parents told us loud and clear, no, I won't see it. I won't remember it. I want something I can stick on my refrigerator. They wanted it by postal mail. And then we actually made a mistake. When we first presented this reminder recall to parents and asked for their feedback, we only included HPV. Total rookie mistake, right? We knew from the literature, don't treat it as special. It needs to be presented alongside all the other vaccines, but we made that mistake despite knowing. And parents said, I don't want to just know about this vaccine. What else are they due for? What else do they need? So we included all vaccines too. And that really points to the value of having these conversations. It's very easy to sort of get myopically focused when you have a area of research and not have a mindfulness of your target and their needs. And so we were really glad that we included this step in our research. And then from the literature, we use presumptive language. And this refers to more of well, you've got these vaccines due today and the nurse will be in a few minutes to get them, versus, well, you could get the HPV vaccine if you're interested. And I can tell you a little bit more about that if you'd like to know more, and really trying to initiate more of a shared decision making versus just assuming they're ready to vaccinate and using that presumptive language to communicate that. And then, as I mentioned, we indicated in the letter the availability of the injection site pain relief as sort of a way that parents could encourage the appointment for their child or reassure them. And then the convenience of nurse visits. And parents also told us, we want additional information about these vaccines. So we included a QR code and URL for doing that. And we've just started to dig into some of the process evaluation literature. And I'm not remembering the exact percent, but it's like just about nobody made use of that. We asked the parents, did you track down extra data? And it was nearly unanimously no. And the clinicians didn't do any better. In fact, may have done worse, because they too said, we would like additional information about how to recommend this vaccine strongly and how to address vaccine hesitancy. And you can see in our audit and feedback report, we have a handy dandy code where they can do the same. And we did some web tracking, and the average amount of time spent on our materials that we worked enormously hard on was 0 seconds. So that piece did not work. But our audit and feedback, clinicians wanted to receive it by campus mail. It stands out a little more. It's not showing up in their inbox, which is always flooded. And we moved into the idea, the mock-up that we shared with them actually showed missed opportunities. So we wanted to convey to clinicians, every time a child the percentage of times a child walked into their practice who was eligible and due, this is the percentage of time you failed to vaccinate. And it's probably not surprising. We're super excited about that, receiving the feedback that way. And that wasn't the only thing that sort of, influenced our decision about how we were going to present this data. Clinicians regularly receive in our practice feedback on different clinical metrics, and they receive it as percent success. And so we thought we better present it that way, because it's consistent with what they're used to seeing when they receive this kind of feedback. And so we did ultimately decide to do both individual and site level percent success. The differentiator from what they ordinarily see in clinical practice, all of our patients in our primary care practices, MAO, are empaneled. And what that means is every patient is assigned to one clinical site one healthcare provider. And every healthcare provider has a panel. These are my patients. This is the little population of patients that I'm responsible for. And they're used to receiving feedback on their patient population. However, very frequently, most frequently, if a child in this age group goes in to see their doctor, it's more of an urgent care situation. They may very well schedule well visits, which they don't do frequently with their assigned and paneled provider. But most often they see other providers. That's why we thought it was critical to provide data to them on, this is your day-to-day practice. You can actually pull the lever of change on this, where a lot of clinicians reported to us, yeah, these metrics, but half the time I don't even, more than half the time, I don't even see these patients. So how am I supposed to affect change? So we focused on those patients who were seen in clinical practice. And then we included this toolkit, as I already indicated, nobody looked at. We created these great videos that I was so excited about showing strong recommendation and addressing vaccine hesitancy. So strong recommendation was to use that presumptive language. And then we shared the case method for vaccine hesitancy. And this method really is a four-step process where you corroborate the concern. So the parent has a concern and you sort of echo it back. And then about me, you say, I have this expertise or I've looked into it. And then the science, this is what the science teaches. And therefore, this is what I advise or advise. And I'll dive into that a little bit more. And we created a series of scripts. And these scripts were focused on the 9 most common concerns that we knew from the literature and our own research that parents have that may trigger vaccine hesitancy. Very, very small percentage of the population is actually anti-vax. Most people who are vaccinated, the reasons for that may be hesitancy. A lot of times it's like, I forgot, I didn't have time. It's not that they're truly against it. But in the cases that they do, these were the 9 most common reasons that were given. The HPV vaccine is too new, worried about long-lasting health problems, not required for school, so I'm not going to get it. It's too expensive. My child is too young, will never be at risk, not sexually active. Oh, we're not here for vaccines today. So we created scripts like the one shown here for each of those that clinicians could use to sort of practice different approaches for addressing these barriers that parents raise. And then we get to the stage of implementing our trial. So we put together and finalized our interventions, and then we implemented it as a pragmatic trial to ascertain what were the independent and synergistic effects of including these additional strategies on HPV vaccination rates. And we hypothesized that we would see a 20% increase for each of these new interventions, and then a synergistic effect that would more than double HPV vaccination if we included both. So we conducted this trial between April 2018 and August 2022 as a cluster randomized step wedge design. And so we randomized at the site level interventions at the site level across 6 primary care practices in southeastern Minnesota. These practices are include salaried physicians, so it's not a fee-for-service practice, family physicians, pediatricians, advanced practice providers, and trainees, residents. And as I mentioned before, we have panel patient populations, which is nice because it allows us to delineate a denominator. And then in terms of eligibility, we get back to this idea of being highly pragmatic. Anybody who shows up who's eligible and due, 11 and 12 years old. We specifically focused on 11 and 12 years because the funding opportunity, the funding we had required it. And so if they were 11 or 12 and were due for the vaccine, they were eligible. And this table summarizes our allocation scheme. So you can see in the first column, we have the clinical practice, the 6 sites labeled A through F. And then if you go across at each site, that's the intervention sequence. So that's how the intervention was randomized across the practices. So we didn't, just to clarify, we weren't randomizing at the individual patient level, we randomized at the practice level. And each of these sequences shows when they were exposed to the different components. And then by step 4, all of the sites received both components. And each of our steps were 12 months in duration. And we had to include this because there's a real seasonality to vaccination where parents get a lot of their adolescents and children's vaccinations in summer for school mandated vaccines. And then we move on to evaluation. So we use the electronic medical record to extract current procedural terminology codes for our primary outcome of receiving at least 1 dose of the vaccine between the first month of eligibility until the last day of the 12-month step. And then I alluded earlier that we also conducted a process evaluation where we collected survey data from both patients and providers to capture some of the broader implementation and service outcomes. And we are digging into those data now. And these data sometimes can feel more useful or explanatory if your intervention doesn't work, because you can start to pick apart, where did this fall apart? And we're still evaluating, and we'll publish these data, but sometimes the value seems more obvious when your intervention doesn't work. You can help explain why it didn't work. So for our primary analyses, which I'll share the results of, per a very pragmatic design, this was analyzed on an intention to treat basis. And we used generalized linear mixed models to assess the effects of the interventions overall and by sex, given the sex difference in uptake. And then for our main model, we used a mixed effects logistic regression model. And for each exposure group, we estimated a single mixed effects logistic model where vaccination status was the outcome. So in each model, we used an indicator for intervention status, omitting usual care as our reference, and indicators for study steps. And step 1 was omitted as a reference. And we also included a random effect for practice site. So our final study cohort included over 9,000 adolescents who were eligible and due for an HPV vaccine. Over half were 11, about 40% were 12 years old, and about 50-50 male, female, and just over 70% were white. And in terms of vaccine eligibility, I mentioned that Mayo's standard practice is to start recommending this at age 9. And so by the time they get to 11 and 12, we saw that about 70% remained eligible to initiate the vaccine, and 30% were still eligible for completion. This is our consort diagram to show the movement of the participants through the different sequences. And this is really another way of showing the diagram I shared previously to show our step wedge design, and shows you how the patients moved through the different intervention exposures in the different sequences, and gives you the sample sizes for each of those. And these are our results. So this table summarizes the percentage of eligible patients who received an HPV vaccine dose by intervention group. And in usual care during that 12-month step, 21.9% of adolescents who were eligible and due received their vaccine. And then when they were exposed to the reminder recall, that moved up to 34%, and for provider and audit feedback, 30%. And then when both interventions were in play, that moved up to almost 40%. And the patterns for males and females and initiation and completion look similar. And here's our odds ratio. So overall, we found about a 50% increase in vaccination when exposed to the parent reminder recall, and more than doubling when exposed to both reminder recall and audit and feedback. We did not see a significant increase for provider audit and feedback alone, except among males. And the patterns for females and initiation and completion were similar to the overall observed results. So we were delighted to have the effectiveness of this intervention, particularly because we were in the field during the COVID pandemic, and there was a lot of pushback against vaccination and a lot of disruption to healthcare. So just to summarize quickly, the reminder recall increased the odds of HPV vaccination by more than 50%, and this was higher than our 20% hypothesized increase. Our audit feedback was at 19% increase, just shy of our 20% hypothesized increase. But interestingly, doing both really did have a synergistic effect. Some of the limitations to note, we only included patients as they turned 11 or 12, and only followed them to the end of the intervention step. So we did this because it allowed us to attribute a vaccine during that time period to the intervention. But that means doses won't be counted if they occur after the end of the step. And this may underestimate the accrued rate, but there's no reason to believe that it would bias the results. And then effectiveness of interventions may not generalize. This may be a somewhat more reticent group because they've already had 2 years of knowing they should get this vaccine, potentially knowing that they should get this vaccine, and had maybe declined or deferred since age 9. And then our practice, as I pointed out, already had several of these evidence-based practices in place when we introduced these new ones. And that's just part of the messiness of doing embedded research. And I also mentioned our trial was underway during the pandemic. So luckily, we were just finishing up step 2 of our intervention, the end of March 2020. So we were able to delay our 3rd step. We had put in place a clinical practice advisory team that helped guide us in terms of starting and stopping on this trial during the pandemic. And we were able to delay for 6 months the intervention, getting us through some of the stay-at-home mandates and the reserve of clinical care for responding to the pandemic. And so our model did account for secular trends, and we did not include any of the data from that 6-month hiatus. So this is the conclusions and implications. Simultaneous implementation of these interventions offers an effective, fairly inexpensive. We're also looking at cost, and it's a fairly low cost intervention. Scalable approach to improving HPV vaccination. And we really recommend that practices use the reminder recall to draw patients in, and use the audit and feedback to encourage providers to use every encounter to vaccinate. And we think that these strategies may be useful for other preventive measures for adolescents. And now adjust. Next steps. So we're continuing to collect and analyze the process evaluation data. We are this week submitting a grant application to expand upon this work. targeting our rural practices. So the practices that we rolled this out in were those most closely tied, they're primary care practices, but were most closely tied to the academic medical center. And we want to move out into the community practices because that's where our rates are lower. And that's also where we have more diversity of practice, greater need. And so we will, we're responding to a kind of a neat funding opportunity that National Cancer Institute has right now. It's a phased funding approach, and these are becoming more popular where you get 2 years of funding. If you perform successfully, then you get the remaining 4 years or whatever. In this case, it's 4 years of funding for the project. And what they wanted to see happen is in the first 2 years of the project, you would work to refine your interventions. And so we're going to use a multi-phase optimization strategy approach to refine these interventions for rural settings. And this is what we've proposed to do and hope to get funding to do. And then we will move into the second phase of funding, which is for the pragmatic trial evaluation across 24 sites in our Mayo Clinic health system. And disseminate. So I had the opportunity to present some of the early findings from the study at the Advances in Learning Health System Science Conference that was planned and led by the University of Minnesota. And I presented the work to the Quantitative Health Sciences Grand Rounds. My clinical colleague, Dr. Jacobson, presented this to the primary care Grand Rounds to get it into the clinical practice. And we recently published this work in JAMA Pediatrics, and we also did a press release to get some media attention to it. And there was a really nice editorial published in JAMA as well about this study. I'm happy to take any questions.
Thank you so much, Lila. That was fantastic. And I think I have 100 questions for you, but first I'm going to let everyone else ask their questions.
So a couple pieces to this. Really, really interesting and super impressive implementation. Who is reporting in the background data papers that you published whether someone received the HPV? Is it the person? Is it the parent? How is that?
It depends. So some of those studies that I refer to are electronic medical record pulls or population-based data. So one of the resources we enjoy at Mayo is the Rochester Epidemiology Project. And it's a data linkage system that combines data from several different health systems in the region and has really good capture of the population. So the further you move out from Rochester, the population capture gets worse. But we do have a nice, in Olmsted County where Mayo Clinic is, we actually over capture. So we overcount the population there compared to census. And I think in our 9-county region, it's about 75%. And then as you move out, it gets to be less. But so some of the studies were just medical EMR data for Mayo only. Some were using the REP, the Rochester Epidemiology Project, which is more population-based, captures other health systems. And then some were surveyed, so it'd be self-report, like the NIST team. But the NIST team, they do validate those parent self-reports. They call the clinician, and they're able to validate many, not all, but doses of the vaccine for that national survey data. Is that what you're asking?
So yes,
Yeah.
perfect answer. Okay. And so is there underreporting in the validated version, or people are pretty good at knowing whether they've had this?
I think the last time I looked at this, that the concordance between parent report and medical record was about 80%. Not terrible. I mean, given the fact that often when you look at concordance rates of self-reported fill in your health behavior, and medical record, that it's usually, worse.
Great presentation. It was great to hear from implementation science researcher. Were you able to capture whether the intervention was able to kind of close any of those rural health disparities when it came to vaccination?
We were not. There may still be potential to do so. So as I said, the 6 practices that we implemented this in, 5 of them are right in Rochester. One is in Casson, which does have a more rural population. And so we might be able to look at the data. We have a new postdoc who's very interested in urban rural disparities. And this is one of the projects we've talked about her potentially taking on. I just don't know if the data will support it, with only one of the practices really having a higher percentage of the patient population cared for there that has a rural residence. But that's definitely the focus of our next effort in wanting to move out into the health system.
Any other questions?
Thank you, Dr. Ryan. Really interesting presentation. So 2 questions. The first one is more about implementation outcomes. I know you said that you're looking at some of the process evaluation. Can you talk about if fidelity is part of it, and if there was one particular site that did better than others? Are there factors that you're able to ascertain that really kind of facilitate success? And the second question is, in your next iteration of study with the most trial, what particular intervention strategies are you looking at to kind of optimize?
Oh, okay, great. So for your first question in terms of fidelity, the nice thing about our interventions is that they were largely under our control. So we weren't necessarily doing an intervention where we were counting on like a nurse or a physician to do something in the clinical practice, but rather integrating interventions into existing systems that, so the interventions went out, the reminder recall letters went out, the audit and feedback reports went out. Where we can kind of talk about fidelity a little bit is, did they read them? Did they remember receiving them? And for the most part, yes. We've looked at those data, and it's certainly not 100%, but something like 80% of clinicians, it may have been 90. That may have been 90. Parents was a little lower remembering. 90% or so of clinicians remembered getting these reports. We sent them every month. And so they did recall and said they understood it, that it was useful, you know what I mean? So we tried to kind of get at fidelity that way. And similarly with parents, although their reporting of remembering getting it was lower. I think it was like 5%. And then in terms of our MOST trial, the multi-phase optimization strategy trial, that we are going to do reminder recall, audit feedback, and then hands-on clinician training. So we are going to use motivational interviewing and training in presumptive language, brief motivational interviewing training, and using presumptive language, but we're going to do more face-to-face training versus put this QR code and do the training on their own.
Our time is up. Just want to say thank you again. That was really great to hear about, and I'll see all of you next week.